Welcome, everybody. I'm Jim Sworer. I'm on the board of directors of the International Society of Service Innovation Professionals, ISSIP. And we're delighted today to have a presentation in our Excellence in Service Innovation Awards series. And in a minute, I'm going to ask Matt to introduce himself and take us through the presentation. But I'll just say that I want to be thankful to Heather Yurku, who set up this series. And Heather is one of our past presidents at ISSIP and has really played a big role in making sure that you get all of these Excellence in Service Innovation Awards presented, recorded, to share with the ISSIP community. So thank you, Heather, even though you're not here right now. And over to you, Matthew.
Very good. Thank you, Jim. My name is Matt Metkser. I'm a physician assistant by training and the division director for mission control and virtual health services in Virginia Mason Franciscan Health, located in Washington State. Dr. Schlicker, how about you?
I'm Jessica Schlicker. I'm a family doctor. I'm the medical director of our mission control and virtual hospital and work with Matt.
Very good. Well, we're excited to share with the ISSIP community today. I'm going to go ahead and share my screen. A little bit about our department called Mission Control. I'm guessing you can see that, Jim?
Yes, I see it clearly. Thanks, Matt.
Very good. So Mission Control is the result of some work in our organization around patient access and throughput and really trying to serve our communities better. We'll kind of talk about the goals for the department, the projected impact, how we've made the impact that we have, our approach, some focus areas of our technology, and then some major milestones and centralization, standardization processes that were a result of the work we did here. Okay, so the idea for having a mission control, which is our clinical command center for our organization, really came about because of a desire to improve access and throughput for our communities. And we'll talk a little bit more about how that was identified and why the need came forward as a priority. But really the goal of our mission control program, our clinical command center, is to enhance the quality and the value of the care delivered across at what that time was called CHI Franciscan, now Virginia Mason Franciscan Health, due to our recent merger. The idea is that we would put real-time data to work and re-engineer the way we delivered patient care and coordinated resources across the organization. We wanted to create a department and processes that were scalable. So as the organization grew, we could grow along with it. And as folks may know who live in Washington State or other similar states, as far as in healthcare delivery, we are a certificate of need state. And so if you wanted to build a new hospital bed, you need to start planning for that years in advance and apply with the state for a certificate of need. And that's fairly costly and a long-term solution, which of course we participate in. But in the immediate future, if you use your existing hospital beds more efficiently, have patients with appropriate lengths of stay, eliminating delays in care, you can actually serve your community better, see more patients in the beds you already have. And so that's where the creating additional 16 beds of capacity comes in, and how you also meet a financial ROI. So the goal for the mission for the department would be to take immediate and measurable action to transform the way we deliver care by looking at current and future needs and empowering our caregivers to really act and to support a culture of basically continuous innovation. We were going to focus initially on access, progression of care, balancing resources across the system, and then shift more towards quality, the post-acute space, and perioperative functions. As far as having a clinical command center like Mission Control, we were the first organization in Washington State and the fifth globally at the time to start a data analytics enabled, including artificial intelligence and machine learning command center. So here's part of the reason why we thought this was important in our market. I've kind of de-identified the players here, but despite a growing market, so in the area that we're located, the market itself was growing, people moving to the area, there's lots of folks to engage with in healthcare. Being the market leader, we were still kind of eroding our market share. Local competitors were increasing their market share, and we found the biggest reason for that was problems with access. So, the patients existed, it was challenging for us to get them through the front door and then to help them have as efficient as a stay as they could to make additional room and get the care to everyone they needed. So, you know, even if the market is there, if you don't have efficient access to your front door, you know, that's one of the risks. And so that was one issue. Another issue is that at that time, the 7 hospitals we were working with, there wasn't balanced occupancy across the organization. So some sites, you can see right here, these are kind of heat maps of the 7 hospitals. Some sites, if you look at time of day and day of week, we're always over 95% occupancy, or we're frequently over 95% occupancy. And the higher occupancy you get in a hospital, you know, over 90%, the more potential problems you have with throughput. While other sites actually, the occupancy was somewhat lower than you would want, you know, 70% occupancy, something like that, where you're having to justify keeping all services open 24 hours a day. For example, if you have a 65 or 70% occupancy, do you need 24 hours of MRI? Well, you would want that available for your patients, but it might not be cost effective to have those services available all the time when you don't have the demand for it at all times. So there was an imbalance in occupancy and resources across the organization as well. So now we'll kind of get into the program and the approach for our clinical command center. Really, the command center has 3 main components if you kind of break it down. The actors, which are the teams, the actions, which is what they do, and the analytics, or the information that is new and different that we use to make better decisions than before. So if we talk about the teams, I'll go ahead and start, and then I'll turn it over to Dr. Schlicker as well. So we have the transfer center, which is a group of highly experienced RNs who coordinate all types of transfers in the organization for all of the beds. So, you know, external from the organization into the organization, between our own hospitals, internal out, direct admits. And, you know, that's important to kind of have a bird's eye view of that function in your health system. It's actually a data-rich department as well for strategic planning. Bed management. So this is a new team we created with Mission Control here, where we actually decided to manage the beds for the whole organization from one place. That way, we would know our resources at all times. We could make system level agreements to use our beds the same way, and we could be better partners with our customers, our patients, and other health systems. We also thought it was important to have the centralized staffing office that does the acute care nurse staffing and scheduling for all of the ICU, PCU, and med-surg patients in our organization, so that we can have equal stretch and sharing of resources to keep beds open across the organization. And historically, some of these teams existed, although didn't function for every site, and they weren't in the same place. And so, you know, having these folks in the same place is really, you know, part of the synergy that you achieve. The last role that I'll mention before turning over to Dr. Schlicker is the clinical expediter, which is a new role we also created, an experienced RN that would use some of our new analytics and the proximity to these teams to really identify delays in care that patients were experiencing and help prioritize them up on the list to make sure that, you know, quality care is timely care. So if you already know what your patient needs, if they're waiting for it, that, you know, there's less value there, and that's not the quality we want to deliver. So that's what the clinical expediter focused on. Jessica, would you like to talk about the physician on duty?
Sure. So our physician on duty program is a group of 12 practicing physicians, evenly split between hospital specialists and emergency medicine specialists. And then we have the chief of surgery and the chief of our cardiology department. Those physicians rotate. So there's one here every day, and they help make critical capacity decisions for the health system in real time. We could not have imagined the new work they have developed over the last year in helping navigate through the COVID epidemic, or the pandemic. But we've been really grateful to have that resource and group of physicians to support all of these teams, making sure that we get patients into the right place at the right time. And really, with the critical capacity constraints that I think most health systems are facing, being sure that the patients who need tertiary, you know, highly specialized care can get that care very quickly. Often that involves creating space that doesn't exist and anticipating needs that we know are coming down the line. So we work very closely with our nursing colleagues in Mission Control to make sure that we keep our patients safe.
And I would say, you know, one thing that Dr. Schlicker found as she was trying to recruit for this team, because these are physicians that already have roles in our organization, was that, you know, despite it being kind of a low per diem rate, you know, less than they would get to do an overtime shift for their own team, they were excited to be able to address some of the headaches that they experience in the delivery of care for their patients. And so these were folks that had wanted an outlet to solve problems and didn't previously have one. Wouldn't you say that?
Absolutely. Yeah, absolutely. I mean, the cell is not, would you like to come in on your day off or on the weekend? The cell is, those problems that you've seen your patient suffering with for so many years, here's a seat at the table, come help us figure out how to do it. And I think it's really been unique. Each one of them has had a very unique skill set that we've really tried to take advantage of solving problems over here. Wouldn't you say, Matt?
I would agree. Yep. We have our downgrade champions and our transfer champions and our lost case champions. They all have a special skill set.
Yeah.
So the last role we have here in Mission Control is the EMS dispatcher. And actually this person is not a part of our organization, but they're co-located here with us. So they work for one of the major ambulance companies, but having them here means that you don't have to send a text or a page or a fax to some other person to let them know you need a patient physically moved between sites. So again, part of the synergy is created by having everyone here together. I would say one of the most innovative parts of this group is the analytics. So we did partner with GE Healthcare to create analytic tiles, and these tiles basically are homegrown real-time graphics that pull information from our various health information systems. So we have data feeds built from our EMR. In our case, it happens to be Epic, but it could be Cerner or Meditech or any EMR, as well as other health information systems like our transfer center platform, our care management platform. And you can have information consolidated and arranged, displayed, configured in a way that allows you to see, for example, every hospital at once, or that allows you to see groups of alerts that would be able to result in a new action. Whereas, using an EMR or some other source by itself or a dashboard that's not in real time doesn't give you the same options for intervention. So basically, each of the tiles that we designed, we pulled a group of stakeholders together and around a certain problem, like observation patient management or surgical and procedural coordination, or people with a high risk of deterioration, and got the right stakeholders in the room, said, what information do you want to have that you don't currently have? And what could you do if it was arranged in the right way and you had people to address it? And so that's where we used our analytics. And then of course the actions, we'll talk about some of those later in the presentation, are the things that we have designed each team member to do based on the new information they have and the proximity to the other teams that they have. So, Mission Control is off-site. It's not on-site of one of our hospitals, because we thought it was important for folks to see and understand that it was going to be a group of people with a system approach, that they weren't approaching their work from the perspective of just one of the hospitals in the system or even the biggest hospital in the system, but they were going to approach it for the organization as a whole. And so, we have actions we've designed with each site to happen based on the different information. So you can't obviously make any type of impact without great partnership at every site. Just, at a high level, with now the 8 or 9 hospitals in the organization, we have our own command center offsite, as I mentioned. We have many walls of analytics at 3 of these sites as well, where they have large displays for the tiles to be used and interacted with. The tiles here are listed. You can see, they have to do with resource or capacity level information. There are also some that have to do with patient level information, some that use machine learning, others that just look into the near future. And everyone in our organization with EMR access has access to the tiles. We didn't want it to be a situation where there's this new data, but only certain people can see it. And so you could kind of play gotcha with someone. Our COO, who had the vision for the department, really wanted it to be transparent to everyone. Whoever wants to see this information, whoever can participate in the improvement of care for our patients would have access. And so, there are several thousand people with access to this information. Jessica, do you want to describe our footprint as an organization?
Sure. So within the state of Washington and actually several sites in Oregon, we have all of these different facilities. And as you can see, the drive time from Seattle to Tacoma or Tacoma to Bremerton is, an hour or more depending on traffic. And I would say that our patients come from a much wider geography even than is shown here. We certainly have patients who come from Alaska, Idaho, Montana down into Oregon. We have a very large catchment area out on the Olympic Peninsula. And so we're really looking at coordinating care across our state and occasionally several states to ensure that patients get the care that they need in a timely manner, which has become a little bit more challenging, when you say, Matt, over the last few years. But I think we're very grateful that our leaders had the vision to do this, because if we did not have the ability to see, the staffing and how many patients are waiting and what services they need at every site in real time, I can't begin to imagine how we would have gotten everyone what they needed. I know, there have been several states that have had to resort to crisis standards of care. That is not something we've had to do in Washington. And at least for us, it's in no small part due to the fact that we can see the problems evolving and sort of anticipate what we need to do next. So we're really grateful that our leaders had that perspective.
I would agree. And Jessica mentioned, the vision and the foresight of the leaders in the organization. I think even with, let's say we had all the resources that we have on our team and the analytics and the expertise, you really need a governance structure to make it work across the organization, because no one at any of these 8 hospitals reports to me or reports to Jessica, or and so you really need a governing body. In our case, we use a board, an oversight board. So one of the things that makes the department effective is that the vision came from the senior leadership, and there was consensus among the organization that this was the right work and it was important work. And then each hospital leader from each site, the nursing leader, the administrative leader, medical staff leaders, are part of the oversight board. So whenever we're not sure how to proceed in a strategic way, whenever we realize we need to do our work differently, we can bring that to the board, we can get consensus, we can get a system level agreement, and then there's accountability through each hospital on that standard work. And you really can't work as a system unless you have some sort of governance and accountability built in. So I report up to one of our vice presidents through the mission control, and in this case, a virtual health oversight board. Jessica does as well. She reports to the CMO for the system. And then you can see some of our teams here on the mission control side and the virtual hospital side. But that board structure really allows us to be effective and actually implement the change that is obvious to folks. Is there anything you would add on that, Jessica?
Yeah, I think exactly what you said about system level agreements. There was quite a bit of heterogeneity in terms of, well, not a lot, some heterogeneity in terms of how units were staffed or how people would get pulled or how patients would be assigned. And I think one of the really important things was we drew together leaders from all sites and practicing nurses and physicians from all sites and talked about, okay, how do we prioritize our patient assignments? And we actually have agreement for that across all of our hospitals. That was, something that I have come to really appreciate, because that means we can go back to that as a source of truth anytime we run into a difficult situation in terms of how to deliver the correct clinical care. So that's just one example, but there's probably a half dozen major agreements that we have that really help us to know how to best serve all of our sites for the greater good.
And I think actually we'll address a few of those coming up. So actually here's some of those right there, Jessica. Would you like to talk through this?
Sure. So I think that the real-time analytics were very, very important. Having really that was a major game changer for us. The management of change was a huge piece. I think that's one of Matt's strengths in particular. I'll rat you out. But having people be willing to let a central service provide some very clinically important services really took a lot of trust and a lot of, we recruited the very best people from each of our hospitals to come work here. I think that was really a good move and helped with that change management. But, sites who are used to operating fairly independently, sort of, being happy with a centralized service is definitely something that we really had to work toward. And then in terms of standardization, we talked a little bit about the patient prioritization algorithm. So in a nutshell, the sickest patient goes first, and then the patient who is, in a department that is under extreme pressure, and then the patient who's been waiting longer, that sort of thing. So that we can really be on the same page with that, right? Our transfer back agreement helps us keep our really specialized beds open by keeping patients closer to home. That's been really important too for some of our smaller sites to feel like they can keep those folks. And then the capacity transfer agreement's been really important too. So when every site is overwhelmed, sometimes there is capacity at one particular site, and deciding how to make that a fair process in terms of which site we offer that space to has been really important. So as Matt mentioned, having the, we created some very specific guidelines to ensure that all of our hospitals stretch the same amount, right? So that if resources are being pulled or redeployed in one place, that there's awareness of that everywhere. So that's been really important, and having the board sign off on that has given us a lot of good guidance, I think.
And I would say,
yeah,
I would just say, as much as anything else, this has been a cultural change for the organization. And so really walking everyone through that cultural change and, kind of proving that you're there to be aligned with them and have the patient's best interest in mind and the caregiver's best interest in mind is really, taken quite a bit of time. You can have excellent ideas for processes, excellent people, excellent analytics, and you've got to do the cultural change work. So.
Yeah, we definitely hired for trust. So one of our bed placement people working today has been working at our tertiary site for 40 years. The physicians that we hired, it was just as important for them to be smart as for them to be humble and to be willing to learn from every member of the team, right? But they also have to be trusted enough that they can call their colleagues at a site and say, look, I think this is the right thing to do. I need you to trust me. And for them to be able to use their relationships in that way has been really good.
I agree. So now we'll transition a little bit into some of the impact that we've had and some of the goals we've set for ourselves. So, some accomplishments from the beginning of the department, which really started in June of 2019, is that we have basically integrated all 7 now additional facilities into a centralized bed control platform. So that was not a function that existed at all before mission control. And so having, all sites basically have transparent, centrally coordinated, standardized processes for bed control has made a big difference. We're able to really utilize all of our resources together rather than trying to do our best work in silos, which is, sometimes what accidentally happens. Every hospital is doing process improvement. They're trying to improve patient flow, patient care, but they're doing it in isolation. And so you kind of leave some opportunity on the table when you do that. Additionally, we've got all of our facilities on the centralized nurse staffing platform. And so now we have transparency into nurse staffing for all sites, how to do incentive pay for all sites, the potential to float nurses between sites depending on the situation. We're creating that regional float pool type functionality. We also have, as Dr. Schlicker mentioned, the clinical expediter and physician on duty supporting all sites. And one thing that we didn't mention, but we'll get into in upcoming slides, is that we record all the interventions that the clinical expediter and the physician on duty create in a way that we can go back and audit them and determine the ROI associated with that, both like in length of stay, financially. It's important for the organization to know that they're getting some value from those roles. And, if you're looking to add roles like that, you want to be able to show how those pay for themselves, several times over, or else it's going to be hard to justify them. Additionally, Dr. Schlicker and some other members of our medical staff and analytics team created a predictive algorithm to balance capacity across the system so that we wouldn't be doing something like a capacity transfer to a site who was going to be in worse trouble the next day and accidentally worsen their occupancy. We've, of course, started the department, as I mentioned, in June of 2019. So had, less than a year before the pandemic hit. And I think that I personally think, and what I hear from the organizational leaders is that the functions that we provide, the team here has been instrumental to our organization's COVID response. Being on an executive incident command call for Virginia Mason Franciscan Health and having all the information to just start making decisions is much improved from, well, let me call my house supervisor and find out how many negative air pressure rooms we have, and then no one being able to transparently see all that information at the same time. And as Jessica mentioned, also multiple standard system agreements have been created and operationalized. So you may remember earlier on, and I'll actually go back to it briefly, the heat map I showed regarding occupancy across sites, where you see, these sites that are in the green with relatively low occupancy, where you're worried about revenue because of volumes and keeping services open, and these sites with red and yellow occupancy, meaning they're so full that we're worried about throughput. We were actually able to make an impact on that. So that previous heat map I showed is kind of represented here. Let's look at September, October, November, so the fall of 2018. You can see these are the hospitals across the top and their occupancy in each box here. Some sites, 3 sites, St. Joe's, St. Francis, St. Clair, extremely full, 93 to 106% occupancy, length of stay being a problem, patient experience being a problem, overtime being a problem, boarding being a problem. And then these sites, St. Anthony, St. Anne, St. Michael's, really with some room to care for more patients and having to justify keeping services open 24 hours, low censusing nurses who want to work their full FTE, all those issues. After the implementation of mission control with our various teams and our analytics, you can see actually in the following fall, September, October, November of 2019, that those differences in occupancies kind of came together. So this bottom section here represents the difference. So for these 3 sites that had the highest occupancy, we reduced the occupancy by 2 to 12%, moving them more towards a manageable occupancy, which improves length of stay, patient satisfaction, provider satisfaction, boarding. And for these sites that had additional capacity to take patients, we've increased their occupancy by 1 to 11%. So now they have better volumes. They are able to justify keeping services open all the time, be able to work people to their full schedule. And you can see that's with the same amount of volume throughout the system. So it's not like we lost volume and we're able to shift. We had the same volume. We're able to decrease the occupancy of our fullest sites and increase the occupancy of our underutilized sites. So that's one outcome that the organization has seen. I'll turn it over to Dr. Schlicker for specific contributions from the POD program.
So I guess I would just like to tell a story to start with this about how the whole team has worked together. So if you imagine, we might get a call from a patient who has a serious neurologic condition, maybe bleeding into their brain, and no health system or hospital in our entire region has an ICU bed. Pretty, unfortunately, and in a scary way, fairly common situation. Before mission control, transfer center would have to call every hospital and try to negotiate something, right? In a world where that bed simply did not exist. These days, what happens in mission control is the transfer center would turn to the clinical expediter and the physician on duty and the bed placement people who are about 10 feet from where they're standing and say, look, we have a patient who has to get in. Otherwise, we have to get them in to save their life. How are we going to make this ICU bed in the next 30 minutes? And they figure it out. Who can they move? Who's gotten better and doesn't need to be in the ICU? How can they create that bed? What tests and studies can they expedite to get a patient who otherwise would have to stay another day? How do they get that patient home to make that space? And then they turn right around and talk to the ambulance dispatcher and get that ambulance sent to get that patient to us right away. So I'm trying to kind of illustrate the team all being in one space is really what makes us able to do much better work on behalf of patients. The physician on duty is a small part of that team, but important, and they are, our team is measured by basically a lot of those actions that also require lots of support of the team. So not trying to say that they're the only ones responsible, but in general, in the first 2 years, they were able to directly prevent 90 lost cases. What that means is there was already an ambulance called for a patient to go from one of our sites somewhere else for services, and we figured out how to keep them in their community and get them what they needed. Or creating an ICU bed like we were talking about. 739 critical patient safety interventions. This could be a patient needing an order for something that they don't have yet, or noticing that a patient was deteriorating and getting them to where they need to be. They also really serve as a facilitator of keeping our tertiary beds. Those are the most specialized beds we have for tertiary patients. And so They are able to really use their influence to get physicians to do virtual consults when appropriate, to travel to other sites when appropriate, really to keep those highest level beds ready for those patients that are the sickest in our community. And then we surveyed our medical staff, all of our doctors, and doctors can be a little surly bunch, but 75% said the physician on duty was highly trusted, which we thought was pretty good. 15% had no opinion, which I thought was weird because I've never met a doctor without an opinion. And just 1 in 10 felt that they were not. And so we were really proud of that and continue to look for ways to improve. There's some cases down here that are kind of fun for the nerds in the audience.
Thanks, Jessica.
Sure.
Would you like to lay out a little bit of the way that team kind of accounts for their ROI?
Sure. So we try to be very rigorous about this, right? Essentially, when we prevent a lost case, when one foot's out the door already, we count that as a hard dollar savings. That's the 90. And then when we create tertiary capacity and it gets backfilled with additional admissions, we consider that to be light green, because you can't, although we know that's occurring, we can't causally relate, we can't prove that every single piece of that was full. So if you look at the dark green only, it pays for about, I can't do that in my head. I think it's about 75 or 80% of the total cost of the program. But if you look at the capacity creation, it's an ROI of 4.7 to 1. And actually, when I pulled our data from the last 6 months, it's actually even dramatically better than this. So this is how we were able to reason out having physician leadership in mission control. And that's what we put together. Thanks.
And I would say, prior to having the physician on duty, the very high level escalations, some of these things would not be escalated at all, but the very high level escalations would go to the CMO or the CMO on call, the associate CMO, chief medical officer for the organization. And now that doesn't happen actually. So those ACMOs are, spending time doing proactive work rather than reactive work. And that work has been taken over by folks who are, to be honest, more competent at this type of care delivery and these issues in general. So it's been a win-win for the senior leaders from that perspective as well. Okay, so if we talk about, one of the other groups that we track interventions for, the clinical expediter group, this is the group I mentioned as a group of experienced nurses who are looking for delays in care. They utilize our analytic tiles to find those delays in care and just the information from other teams, bed control, transfer center, physician on duty. So they have, standard work they do where they are trying to identify barriers related to delays in imaging. So, CT scans, echocardiograms, nuclear medicine stress tests, and then, service delays like maybe occupational therapy, physical therapy, provider consults. So they have a way to identify quickly. You can filter it by unit or level of care or hospital, patients who are experiencing delays. And we especially focus on those patients who are in an area of high demand. So if we notice that there's a hospital that has a lot of patients boarding in the emergency department, in other words, they have admission orders to go upstairs, but they don't have a bed upstairs, and they're all waiting for a telemetry level of care, let's say, we can go to the telemetry unit in that hospital and look at all the patients and see if they're waiting for anything that might help expedite their throughput. So, maybe they could discharge if the results of this study were back, or if they have, this oxygen saturation checked, or there's different things, we can actually check for that, address it proactively, and make capacity at the places with the biggest bottlenecks. So the clinical expediters do this kind of standard work daily. They have intervention designed with each team, with each department. We've given them special access in the electronic medical record to see, for example, the patient prioritization list for the CT techs or the echocardiogram techs. So they see the same thing that those radiology technicians see, and they can help have discussions with them to prioritize certain patients up higher on the list if it makes clinical and throughput sense for the organization. And that, of course, results in decreased length of stay, more quick delivery of care to patients who need it clinically, and overall better satisfaction. So you can see we kind of break out their interventions by site. Those are the two largest sites there: St. Joseph's Medical Center, St. Michael's Medical Center. St. Elizabeth on the far end of the spectrum. On the other side is a critical access hospital. So this kind of matches their volume of interventions with the total volume of patients at those sites. when you kind of just list out some of the interventions from January 2020 to July 2021, they were able to create, this team was able to, with their colleagues on site and in mission control, create 167 strategic beds. So in other words, we have a patient coming out of the operating room who needs a neuro ICU bed. That bed was not currently available. So instead of that patient boarding in the PACU for hours with maybe a nurse who's not specifically trained to care for that type of patient, they were able to help the team make multiple moves, expedite the care of other patients to make that strategic bed available. 464 times, able to get a diagnostic imaging scan moved up for a patient, so eliminating or reducing that delay. 581 times, they were able to catch a patient who was approaching a surgery or a procedure and did not have a order in the chart to stop feeding them. That's important, from a medical perspective, not to feed patients before some procedures or surgeries, or else those could be delayed. So that helps us better use our operating room time, procedural time. And you can see some other types of specific exams that this team has helped make possible for a patient more quickly. They also identify sometimes duplicated or outdated orders to clean up a medical record, which reduces the potential for errors. 57 times in that time period, helping a patient stay for a shorter amount of time in the ED and get to their targeted bed that provides the right care for them. 173 times, there was a patient who was ready for discharge except for one thing, X thing, and they were able to help get that addressed so the patient could go home. Interestingly, for those that are involved in the healthcare field, they know that when you're admitted, you can be admitted under several different statuses, and it depends on the care that you need, but it also makes a big difference to how much you have to pay out of pocket as a patient. And so there's been 256 times in that time period where this team identified that the patient was in fact not an observation patient, but an inpatient. That makes the burden out of pocket to that patient less, and it helps actually with reimbursement for the organization as well to get them in the right status for care. There's some other information there about delays as well that the team has identified. And then we have some ROI associated with each of these things. The conversion from observation status to inpatient has a very straightforward ROI. The organization gets paid a certain amount for observation patients and a different amount for inpatients. But the cost of care delivery is about the same. So if you get them in the right status, the organization comes out ahead on the reimbursement for that patient, and that patient actually has less out-of-pocket cost as well. Whenever you keep a patient from having a surgical or procedural delay, you can think about reducing the days of care. If you think about, depending on the organization and the region of the US, the cost of care might be, $500 to $1,000 a day. So anytime you can minimize those days where you're just sitting in a bed, you reduce the cost of care, you expose the patient to less potential for medical errors because they get to get out of the hospital sooner, and you get to make a bed earlier for the next patient down the road. So that's what this ROI has to do with. It's the same idea with getting a patient to a scan or a procedure that they need earlier rather than later. You reduce the cost of care and you create additional space to care for additional patients. So I think that is essentially the bulk of our content, but we're happy to answer questions from the group.
Wow, that was fantastic.
Thanks, Jim.
I actually have a whole lot of questions, but I also have a couple ISSIP operational things to cover as well. So unless Heather or Amit have a burning question, I'll jump in, and why don't I share my questions in the Slack in case you guys want to take a look at all my questions. I think you did answer some of my questions about the sustainability and ROI and things like that. So the latter, some of those questions from earlier. But I do have two ISSIP related questions. The first one's really trivial, but did you want a PDF of your presentation posted with a recording on the ISSIP website, or do you prefer not to do that?
That's a great question.
Presentation.
I would say sure, I guess. Sure, yeah.
Okay.
That'd be great.
So send me a PDF, Jim Sporer, or you can send it to Heather, but if you send it to me, I'll be posting it to the website. So send me a version of your presentation that you'd like posted, and I'll put the recording up. and the PDF. The other thing is, I was wondering if you want to publish any of this in any way, either in a peer-reviewed conference or as a book, because ISSIP can help with that as well.
We're always up for that.
Yes, yep. And Jessica tends to lead the way on our publication, so I think we would be interested.
All right, I will send Jessica information on both of those things that ISSIP can help with. Yeah, we have a book series at ISSIP with about 50 books on service innovation, you know, everything from cruise ships to I don't know what. We do have some healthcare, smarter cities, things like that. So that would be great. So I'll send Jessica that. Yeah, as I look through my various questions, the one that I'm most curious about is like, how many people did it take to set this up, and what kind of skills did they have to have? How big a team? You know, was it IT, medical, design, management, HR? And you talked about culture change. Did you have a culture change specialist? Do you have that information?
Sorry, that makes me, I think that's Matt. I think Matt's the culture change specialist.
I would say it was very difficult to know exactly who we would need in the mix early to make this successful. To your point, tons of IT help, you know, software engineering help, hardware folks, you know, like all members of the care team from every hospital. Was basically, we set up very early on kind of a core team and a steering committee, and those included, you know, experts from every site. But to your point, lots of folks that were not strictly healthcare either. You know, data engineers, IT professionals. We had early on help, especially from the GE team as well. You know, when they help facilitate some of those meetings for the analytics design, they kind of help bring groups together and get their desires crystallized. But you know, we also found some of our champions along the way, and so we were open to help and input from anyone who wanted to dive in with us. And we're a fairly flat org structure in the department, and that's pretty fun as well. Anybody can come forward with an idea, and we took help wherever we could get it. So, you know, as far as like on a daily basis, and we're talking about, you know, affecting operations for about 1,600 beds, we have probably 25 people working on it, like in a 24-hour period. And, you know, the team overall is, you know, roughly twice to a little like 2.5 times that size in general, because, you know, we're a 24/7 operation. We have all those teams there. But, you know, and we kind of, the staffing kind of goes up and down as the intensity of work goes up and down. So at night, we're still open, but we have less members of each team present because there is less work happening. You know, but mid-afternoon, early evening is a lot of folks in the department, because that's when a lot of work is happening. So yeah, I would say it would have been difficult for any leader to estimate the amount of work that would happen, you know, to create the team, and who would need to be involved and who would have an interest. What are your thoughts, Jessica?
Yeah, I totally agree. I think one of the really important things that we learned is that, you know, centralizing services is pretty scary. And the reason that is because people care very deeply about the care that their patients are getting. So when you get involved in that, it's really important to be willing to field even very difficult criticism very open-heartedly, I would say. We learned that, you know, the more vigorous of frustration, the more important it was to engage with that person and really do a lot of site visits to the hospitals and be dogged about, you know, what is every detail of this problem that we're encountering, and be sure to follow up very, very well on those things. You know, people have to believe that you're going to take them very seriously, because it's not going to be a smooth sail, right?
Yeah.
So, when, you know, you have to be available. I think Matt and I both learned that we've needed to be, you know, 24/7 available, both to our teams and to all the hospitals, to build trust. And then one of the greatest things that we were so lucky to have, I think I mentioned, is that a lot of these team members have been around a long time. So even if the idea of a command center was very scary, they're still talking to Barb that they've been talking to for 30 years. And if she's on board with it, they're going to get there. I think that was really, really important.
Yeah, and to answer Heather's question is, some of these teams, like the transfer center by itself was created, maybe close to 10 years ago. It looked a little different, but it already existed. So some of this work was importing those teams and putting them in the same room. But for the teams that did not exist prior to this, yes, we went through an interview process and handpicked internal and external applicants based on all those things Jessica mentioned, expertise, level of trust that they could achieve, openness to change. And I think, what we know we are interviewing for now is different than what we assumed at the beginning earlier. We're definitely looking for high levels of competency and all those things earlier, but we underestimated probably the amount of stakeholdering that each person would have to do, right? That working with the on-site teams to help them understand a plan, to manage expectations. Like Jessica said, there is a sense of loss sometimes when a function that used to be managed exclusively at your site goes to a central location. And so you mitigate that by having great people, by hiring people from those sites, by showing them the benefits. I think that's an opportunity for us too, actually, is to do some more internal publicity within our organization to show folks what we're working on behalf of each of their sites and what we've accomplished, on a daily, weekly, or monthly basis. And we have continued to provide forums for people to give feedback constantly. So aside from the board structure, which I showed, there's a level beneath that that's mostly made up of director level folks called the Mission Control Core Team, which meets every other week. And we keep a decent part of the agenda available for folks to talk about issues or concerns. And so, everyone gets to voice, how it's going.
Yeah, part of it too is sometimes we encounter problems as a health system that seem sort of unsolvable. And we've had to just make up a way to fix that, right? So when all of the health systems are overwhelmed, we're still going to care for our community somehow. So having these teams in one place and then really reaching out to our hospitals and saying, look, we've got this list of patients. Let's get everybody on the phone. We're going to commit that we're not getting off until they're all cared for. And I think that when you do that, and when you record every phone call, when you're willing to share every intervention and every detail, which we are, I think over time people realize that really we are all on the same team. Yeah.
Yeah. And I like Amit's question. I think that is a common concern from members of the public at large as well, as so you've got more data, you've got better data, both on your healthcare systems, resources, but also on individual patients. So how do you continue to protect that information while using it to the best of your ability to care for patients? And so, as I mentioned, folks have access to the analytic tiles in our organization, but only the same folks that have access to the electronic medical record anyway. We actually access the analytic tiles through through the Microsoft Azure cloud network, through firewalls. And so, that information cannot get out aside from having, VPN access and all those pieces. So, it is a challenge. It is important, but we're not necessarily creating new information. We are coalescing information into more usable areas for the team to take action on. Interestingly, the tiles are, real time. People will frequently ask us, well, what about this, and this, from last week, or how's that trending? That wasn't our initial design, although we have a great analyst now who actually can synthesize tile history in the form of, it's stored in JSON format, JSON format, and he's able to decipher that and collate it and present some intelligence with us. But that wasn't one of the initial functions we had. We were looking to be primarily just real time, but we found that we've taken more of a consultative role recently for the organization to help provide intelligence for better decision making based on data that exists in our electronic medical record and in the tiles. And so that's been kind of fun.
Hey, Matt, can I give an example of that?
Sure.
I have to tell you about our analyst. He's completely fantastic. His name is Hitul Shah. And a few days ago, one of our hospital leaders called and said, we have this opportunity to open this particular part of the hospital and cohort COVID patients there. How many do you think we'll have? At what speed will we be able to fill it? And, how should we staff it? It's kind of a major operational decision for them. And going to our highly skilled analyst, within about 15 minutes, he told me we have this many average COVID admits per day. This many are within 30 miles of that hospital. In the past, we've been, successful at transferring patients about this often. And he had better data than we would have been able to get in a month, before mission control in about 15 minutes. And so that's something, whenever we have an opportunity to serve one of our hospital customers that way, we want to be all over it because we want to be the people who can get them that information. And having a skilled analyst has taken us way, much further than we could have gotten with my computer skills. That's for sure.
What I saw one of Jim's earlier question was, why the initial inequity in hospital occupancy across sites? A few pieces for that. One is differences in population. We cover, as Jessica showed, a large geographic area, different socioeconomic statuses in those areas, different population density, but also not all of our services are offered at every site. So we have, tertiary sites that have things like neurosurgery and cardiothoracic surgery, which are not offered at our individual small community hospital or critical access hospitals. And so there's also kind of a referral pattern that happens within our organization that has the potential to keep some sites fuller than other sites. And so the demographics and the services offered, I think, are a big part of why without intervention, you would have more imbalanced resource utilization across sites.
Great, thank you. Yeah, this has been an amazing talk, and would love to follow up on those ISSIP publication opportunities. And this has really been great. I do have to run to a 1 o'clock, so and this is a Zoom I'm going to need, so I'll have to stop at some point. But thank you so much, Matt and Jessica. This has really been awesome. And Heather, thank you so much for setting up this series. I just learned so much more from these talks about the Excellence Awards than I do just reading the material. This is awesome. And Amit, thank you for joining, and thanks for the good question. And Matt and Jessica, I'll be following up with you both. And on behalf of ISSIP, thanks again, everyone. And bye for now. Have a great rest of the day. Have a great holiday season as well.
Thanks so much for the opportunity. We appreciate it.
Bye-bye. Thank you.
Absolutely. Bye now.